I'm Chris McLeod. I'm one of the electrophysiologists at Mayo Clinic in Florida. And this is one of our online offerings in anticipation of our board review course that's coming up. We thought this is a nice forum for discussion of interesting cases and just highlighting some key components for budding electrophysiologists and EPs who want to refresh for the boards. There was already a session looking at some really nice SVTs that we presented around 6 weeks ago, and this is on ventricular arrhythmias.
Thank you, Chris. Welcome, everyone. This online webinar is supposed to add on to our core board review lectures and give you some context and to test your knowledge. Today, we have two excellent colleagues who are going to highlight some cases and bring out some points that are relevant for the boards. The first presenter would be my colleague, Dr. Dinesh Kella. He's a practicing electrophysiologist at the Jacksonville campus in Florida. He is the go-to lead extractor in the Florida region. One reminder is if you have any questions, comments, put it in the Q&A part of the Zoom window, not in the chat. So at the end of the case, we will get to those questions and get some input from Dr. Kella. Dr. Kella, thank you for doing this.
Just while Dinesh is getting things pulled up, just putting a plug in there for our EP board review course, which is August 22nd and 23rd. You can message us or reach out anytime if you need more information about that. We have some outstanding speakers, including Bill Stevenson, lots of the established educators at Mayo Clinic, just an excellent panel. So think about it. It really is focused on improving your candidacy to ace the boards, and then also some just key components for learning and your practice. Sorry, Dinesh, go ahead.
So I'm going to talk about entrainment and reentrant arrhythmia ventricular tachycardia. And as part of this topic, we're going to go over the principles of entrainment mapping in structural VT cases, and then review the role of pacing output configuration, how it can be, how is it important to have the right output when you're pacing to entrain the tachycardia. So my patient is a 75-year-old gentleman. He has a history of mid-LAD infarct before. He underwent PCI for it, but EF had dropped, EF around 40%, and prior to that, he had low EF. He got an ICD for it. And he did well for many, many years. Then all of a sudden, he started to develop ICD shocks related to monomorphic VT. And he was placed on amiodarone, but he wished to undergo EP study and VT ablation. So he was brought to the EP lab. And during the study with programmed ventricular stimulation, the following VT was induced. So cycle length is about 420 milliseconds. This VT was reliably reproduced whenever it was terminated during pacing or if any cardioversion was performed. So before I go any further, I want the audience to take a look and think about the exit of it and try to figure out where we should start mapping for this, or where would the circuit be for this tachycardia.
While the audience is thinking about this, just looking at the exit, and so we're thinking this is reentrant, and I guess driving home the key, principle here that with reentry, the exit doesn't mean this is where you're going to ablate. As Dinesh said, mapping is the key here, and if the patient is hemodynamically tolerating this, then these are really fun cases where you get some super useful information from your catheters, and you can build an electron-atomic map of the wave fronts.
I think the key, as Chris mentioned, is the morphology won't determine where you're going to ablate necessarily, but will give you an idea where to start your mapping and everything. And whenever you look at this for the board review in clinical practice, just trying to figure out simple things. Is it the right ventricle, left ventricle? Is it the septal or lateral wall, base, mid wall, or apex, superior versus inferior? And just going systematically through it 2, 3 AVF, are they positive or negative? Here they're negative, so that means it's superior axis. And so things are coming from below to up. So inferior wall is where you would be looking for this. Then looking at the right bundle versus left bundle morphology in V1, it's all positive, so more from the left side. Then everything seems to be negative and transitioning early to be negative. That means more towards the apex. Then again, one is positive, suggesting more the septum than anything else. And so thinking of it like going consistent with the infarct of the patient, the left ventricle, mid-LAD territory infarct. So apical, inferior, septal is where you would be looking for this. Anything
So,
else?
Danesh, one other thing to think about is you have the negative complexes in the inferior leads, right?
Mhm.
But then you have a tiny R wave in the beginning of those negative complexes. That tells you that this is not epicardial. So if you have a QS, when you have that R wave, at least the activation is going from endo to epi. So
Yes.
this is a case that, you know, upfront epicardial mapping is not something that you're thinking for this patient.
Absolutely. And so this patient was tolerating the VT hemodynamically well. And so we started with mapping, and we were using the NAVEX mapping system. We had a grid catheter, and the grid catheter was placed in the left ventricle at the near the apex and the apical septum. And these are the signals that we saw, and it got us excited. And I want the audience to take a second to look at it and see if there's anything interesting. And either one of you, if you want to comment on the signals or anything that is interesting to you.
It's always interesting how quickly you can forget about all the different catheters you have to use. And here you actually have another catheter, which is your RV apical catheter.
Yeah.
And so with this one screen, you can really get a sense that at least the activation, it's either extremely late on the RV side, or it's extremely early, but at least some of the circuitry is somewhat differentiated by the septum. So kind of looking at all of the different catheters, and when you're starting out with these, it can be very overwhelming looking at a screen like this. And just the same way that you're looking at an ECG, look at these. So start out by kind of orienting yourself. Look at the far left. You see you have all of your 12 leads on the left highlighted for yourself. And then you see the RV proxy distal and then the multipolar catheter. And then systematically just evaluating what you're seeing. And this beautiful double potentials, almost getting into diastole, I guess, like a little early diastole. And then there's this very tiny, beautiful signal that Dinesh is highlighting that's mid diastolic. So you have quite a bit of that cycle length of this VT on this one slide.
Yeah. And I mean, when I was making this slide, I had this decreased speed show up, and like I thought of going back and removing it, but then as Christoph said, can be overwhelming for the boards or starting as a new fellow. So just slow down and look at it in a systemic fashion. Sorry.
The other thing that just to consider here is this grid catheter, and you can think of any multipolar catheter. These electrodes are so closely spaced; they're a couple of millimeters apart. And if you move your calipers just to that C electrode there, Dinesh, just the beginning of C1 to the end of something like C4. And you can see just how much of the cycle length, as Christoph was saying, but also just how slow the conduction is there. To travel 2 millimeters, it's taking probably 200 milliseconds. So very diseased tissue, just to get across that grid, or if you had an Optrel or an Octarad, doesn't really matter. It's just that closely spaced electrode, and it's very diseased, slow tissue. So let's say this is not even participating in this tachycardia, because we're obviously going to need to look at entrainment. But this is arrhythmogenic substrate if you ever needed it. It's really slow conduction. Sorry, Dinesh, go ahead.
Excellent points. Excellent points. So, question here: would you just ablate this or explore? Because, as Christoph, I was pointing to this signal, sort of forms in that like mid-diastolic area. You have the QRS, ventricular activation, and you have this. Isn't that what we talk about for isthmus? Just go like find that mid-diastolic signal and ablate, or do you explore further?
Well, it could be unrelated. You're recording something, unrelated to the participation in the circuit. That's an attractive signal in tachycardia, but we want to make sure that it is not a bystander. It's actually participating in the circuit before changing the substrate.
What bystander? This is VT, right? There are no bystander. There are no innocent bystanders in it, right? This late in the signal.
You can have some passive activation. Certain parts of the circuit can be passively activated, not actively contributing to the VT circuit. It's nice to confirm your findings by pacing, doing some maneuvers, or even if there is some variation in cycle length. How is that cycle that signal to signal change in relation to the other components like QRS to QRS? So if that per signal to signal change predicts the next QRS to QRS, that means something. But still, would be nice to do some maneuvers, have a little bit more confidence before ablating.
Excellent. Okay. All right. So we switched out a grid catheter for the ablation catheter in the similar area. And this was, again, what I was thinking was a similar signal that we had seen before. And we do something here. We pace and train the tachycardia. So, Chris, Siva, would it be possible for anyone from audience to comment, or would you guys like to go over it?
Yeah, I think we can go over a few key things, and then certainly anyone in the audience can weigh in. I think nice to start off with just how do we know that we're entrained?
Right. So, like, first making sure, like, what the cycle length of the tachycardia is and is about regular or not. And looks here about regular. Every beat is following where it's supposed to. And then this is how fast I'm pacing. So picking a point in QRS where I can reliably measure and make sure all my QRS are driven to that pacing cycle length.
And that always comes up on the boards. There are always several slides where you haven't accelerated the tachycardia to the cycle length of pacing. And they're asking you about the response to entrainment. But that first thing that Dinesh just pulled up there, did you really entrain the tachycardia, making sure that the VT during entrainment is at the cycle length of pacing?
And the other thing is, like, you will have tracings where, like, this stem is actually giving to this QRS. As you can see, this is where we were pacing at the cycle length. If you see, this is the QRS being generated by this stem, and then the tachycardia resumes at the tachycardia cycle length. Goes faster.
So can I just go into that real quick? What Dinesh did here is he is first off showing that each QRS is going at a faster cycle length than when he was in VT. By this way, he's showing that he's accelerating the tachycardia. And then he's finding the last accelerated beat, because the last accelerated beat might not be the one that is immediately after the last pacing spike. And the way that he's doing that is just taking the calipers, putting it on the and Dinesh, can you pull it over, just showing like if just before you show the last accelerate beat? Yeah, so okay, and then go to the two QRSs. No, go to back one more. Go one back more. Yeah. So this is at least how I started. I show these two because I know the last one had to be accelerated, and then I walk it over one more. And if that's the same cycle length, then I know that this last pacing beat went to that very last one right there. And that's my last accelerated beat. And then I would pick it up one more to prove that the next one is now back towards the regular tachycardia cycling.
So this is the tachycardia resuming.
And what we're doing here is we're showing you guys also that really entrainment is a very almost a protocolized step-by-step fashion. If you do it organized, then you can be more sure about your answer and what you end up concluding.
Yeah, and there's so much to discuss here. I have to say that the first thing I also look at, in addition to have we accelerated the tachycardia, is it concealed or manifest? So it gives me some idea of where I am sitting in relationship to the isthmus. So what do you think, Siva?
When I'm looking at the VT overall, it looks very similar to the paced QRS, right? Except that right after the pacing spike, and if I'm looking at lead V3 to V6, you have that sharp downstroke. V3 to V6 at the beginning of the QRS, right after the pacing spike. Now we don't see that during tachycardia. So one may think that this is manifest entrainment. In fact, it is just the TP fusion or the pacing pacing spike coming on the T wave, which gives this illusion of that you may be having manifest. But in fact, this is like almost like a concealed fusion.
And the other thing is here too, like if the pacing spike in here, you have a QRS that's further away from the pacing spike, so you can compare the two QRSs. But I agree with all of the points, and then like this is to me is concealed, and like the next thing is to look at what your return signal is on the site that you're pacing from. So here we are pacing from ablation distal. You get a lot of signals here. So Siva and Chris and Christoph, like how do you determine is this the guy, or the guy is not here, somewhere here? What would be your like the signal that you would measure here?
Yeah, that's a great question. So whenever you have a multi-component signal, you'll be worried about some of them being far field. So one way to really appreciate the signals on your pacing catheter is to unclip, change the gain so you actually see the signal. The other clues are you also have a proximal electrode pair. So you can see that the proximal electrode pair, there is a signal that is not sucked in. So that is like a far field component that lines up with the first part of the component on the distal signal. Okay, so that one lines up with the first part of the component on the distal. So that to me is a far field component. Whatever is sucked in is the high frequency signal that is afterwards.
Got it. So what Siva was saying is that like if you look throughout the pacing spike on proximal, this guy right here, this signal is not being sucked in, which corresponds to this, and it corresponds to something on the distal this. So this is unlikely the signal that's being sucked in, and also you see it like sticking out right here. So it's probably this signal here. That's the one that we should be measuring. And this is your post-pacing interval or return cycle length. And 338 here, like this is an arbitrary number. And if you compare it to your tachycardia cycle length, right here, if you compare it to the QRS, it's pretty long. Like if I just close my caliper here is the difference. So 117 compared to 338, this is an addition to what we are getting. So pretty long. So this will be indicative of that this is not in the circuit. And so, Siva, any comments about this?
The fact that you're having the last entrained QRS, right, is such a long stim to QRS. You are in a protected corridor, or like a blind loop that is attached to a deep protected corridor. So you're not in the isthmus, not near the exit. So inner loop, bystander attached to the inner loop could be one possibility. But certainly, even though it's a diastolic signal, this is not the place where I would ablate.
Exactly. So we'll just go over these things that Siva was talking about quickly, and then we'll see like whether anything happened when we ablated or didn't ablate and found something different.
Yeah, just
So
to drive that home one more time. Just go back for a second, Dinesh. It's so important to know which of the signals that you're pulling in. That's the signal you're going to measure to. And I know that we've gone over that, but just look carefully at which is the signal that's pulled into pacing and which are the ones that are not pulled into pacing. This fools electrophysiologists all the time and definitely is going to be testable on boards.
So this is your classic diagram that you'll see in all textbooks, like this imagined 3D circuit or a circuit of VT imagined in 2 dimensions. And imagine that this whole slide is your ventricle. This is the circuit within it. So you got these anatomical obstacles, scar area that do not conduct at all, a protected isthmus that conducts slowly and conducts preferentially in one direction, and this allows the re-entry to happen. And there are other places in this, like you get far field areas, you get something within the scar that's protected but is far from the circuit, and then the exit of the circuit, and then where the tachycardia again goes back, enters into the circuit. So when you entrain or accelerate a tachycardia, let's say this tachycardia is going at 300 milliseconds, what you want to do is pace from somewhere a little faster than the tachycardia cycle length. So typically 30 milliseconds less than the tachycardia, and goal is not to interrupt it, not to break it, so you can interpret after the tachycardia resumes. And when you start pacing, you generate wavefronts that start to go as you pace gradually into the tachycardia. And what you're doing is pushing ahead and making it go faster and come back quicker than what it was going at. What we talked about, like making sure that before you entrain that the tachycardia is stable, and when it comes back, it's along the same cycle length, it's stable again. This will show up in boards where you have an unstable tachycardia, and they will ask you to interpret the findings of entrainment, and then you cannot really, if your tachycardia cycle length is not stable. Did you accelerate it or not? Like we were going through, making sure that you actually got into the circuit. Did the tachycardia continue? And then looking at QRS to look for concealed versus manifest fusion, looking at post-pacing interval in relationship to tachycardia cycle length. Then we'll go over STIM to QRS that briefly Sipa mentioned, how it can be important in interpreting the site of where you are in the circuit. So fusion, again, for those who are starting in EP, fusion, like if I'm pacing far from the tachycardia, from the circuit, then I'm going to have 2 wavefronts. One is from my pacing side, one is from the tachycardia. They're going to collide. So what you will see when you're pacing, it will look neither like tachycardia nor like pacing, something in between. The faster I pace, the more it will look like my pacing morphology than the tachycardia itself. If I move my pacing site within the circuit, then there is really no other wavefront colliding with the tachycardia wavefront. So my pacing pacing QRS morphology is going to look same as the tachycardia, which is called concealed fusion, and that means like you're closer to the circuit. Then looking at post-pacing interval, what we are doing is like anywhere if you put a catheter in the ventricle when this VT is happening, you're going to record a signal. And for a stable VT, you're going to have that signal come at the same time, 300 milliseconds. Let's say we are recording somewhere here. If I pace from a remote site further away from the circuit, when I come off pacing, when the circuit resumes, when the tachycardia comes back and the signal comes back to the site of pacing, it is going to take 300 milliseconds, the cycle length of the tachycardia, to get back. An additional some time, the time it took for you to go into the circuit and then come back. So the longer your post-pacing interval is in comparison to tachycardia cycle length, you're further away from the circuit. As you get closer, this timing is going to get shorter and shorter, the return cycle length. And once you are within the circuit, then this is going to be typically close to 30 milliseconds plus minus to the tachycardia cycle length. It should, an ideal circuit, be the same as your tachycardia cycle length because you do not have anything additional to travel or come back to. And within, like, how do you determine within the circuit where you are? Are you in this critical isthmus? Are you at the entrance or the exit? You can look at STIM to QRS. If it is long, the stim to QRS to tachycardia cycle length, that means you have to take a long time for it to, from where you're pacing, to get out to the exit. So you're more proximal towards the inner loop or towards the entrance of the circuit. And this is from the classic paper looking at stim to QRS and tachycardia cycle length, the relationship. And if it is more than 70%, then you're more in the proximal part of the circuit. As you get closer to it, then your stim to QRS is going to get shorter or more midway compared to your tachycardia cycle length. As you get to the exit, there's not really a lot of interval for you to cross where you're protected in this isthmus. Your stim is going to move towards your QRS. So that is going to be less than 30% when you look at stim to QRS to tachycardia cycle length. Other possibilities that we were seeing in our case was like, what if you have manifest fusion, but your post-pacing interval compared to tachycardia cycle length is equal or within the 30 milliseconds? This can happen if you're in the outer loop, because in the outer loop, you're still close to the circuit, but you have a wavefront that is going away in the healthy or relatively healthier myocardium that can cause manifest fusion, but your post-pacing interval is going to be within 30 milliseconds of tachycardia cycle length. This is important to recognize, mainly for academic reasons, but like ablating here won't make a difference because, again, you have healthy myocardium. Ablating the healthy myocardium wouldn't make a huge difference. And then what we were seeing in our case is this blind pouch that Dr. Malpura was talking about, the innocent bystander within the tachycardia, or within the scar, I'm sorry, where you had this protected corridor where you didn't have any way to get out and create this manifest fusion. The fusion was still concealed. You couldn't go out, have another wavefront. But it was still taking you long to get to the circuit and come back because you were away from the critical circuit. And again, ablating here wouldn't make a difference because it won't affect the tachycardia cycle or this critical isthmus. So this I will leave in our slides for you to review in interest of time. But again, it's just going through that classic algorithm, trying to look at entrainment, concealed versus manifest, then post-pacing interval, then the tachycardia cycle length and relationship of stim to QRS to figure out where you are within the circuit. Coming back to
Can we go back to that just for a second, Dinesh?
Mhm.
So it's just such a powerful tool in entrainment, and you'll end up relying on it not just obviously for ventricular arrhythmias, but for atrial arrhythmias in a very similar way, using your activation sequence as sort of a surrogate for the QRS, just in your atrial catheters. The algorithm also just pointing out the post-pacing interval equal to the tachycardia cycle length, or your stim QRS to equal to your EGM QRS difference. It's either or. It doesn't have to be both, and they both are equally valuable. So sometimes maybe you're not able to measure something as carefully, but because of intracardiacs and lots of signals, if your stim to QRS and your EGM to QRS is equal, you know that you're in the circuit. So it's a very useful tool in addition to just another way of looking at entrainment that Bill Stevenson put together.
Just coming back to our slide, like, I mean, everything Dr. Malpura had pointed out and others had pointed out, like looking at, again, like, is your tachycardia stable? It was stable. Then looking at, did we accelerate, and which is our last accelerated beat? Then looking at the QRS manifest versus concealed. Then trying to figure out the signal that we are sucking, and that's where we are pacing from. And then looking at its relationship to the tachycardia cycle length. Or the other thing that we saw from algorithm and Dr. McLeod was pointing, again here, if you had just looked at stim to QRS versus this EGM to QRS, again, it would have been very different. And would give you the idea that this is a bystander and not part of the tachycardia circuit or critical part of the tachycardia circuit. One more entrainment slide here. And in interest of time, Christoph, if you want to just quickly go through this.
Yeah, so okay, so here we see, again, I can kind of look at starting with the QRS of the pacing one and comparing it to the QRS of the what I believe is the last accelerated beat. or of the VT. It overall looks like concealed entrainment. The last base QRS looks like nearly identical to the tachycardia. We can see that you have multi-component signal here on your ablation proximal and distal. That's really helpful to help see what you're capturing. Here you can really nicely see, it's really tough to see on ablation distal what you're actually truly capturing. But you're seeing on proximal, there's this small signal, and then that looks about the same distance as this more far field signal. So if you can just really quickly point out,
Like
there's
this
small
on this
signal
side
on
of it.
prox. Yeah. And then I drop it down. Actually, I wish let's see, maybe I can put guess I can annotate this. Yeah. So just going organized, again, concealed fusion. We then have, we show that basically this, and then this is probably our last accelerated beat, and you have your calipers to show, but I can visually see the distance between this is a decent bit further.
Yeah.
Than
Yeah,
this
this is
one.
your last.
And then looking at that signal, this is again that far field signal on prox that I'm looking at. And I correlate with this, and I can see that this is right here. So probably I'm capturing this little signal right there. And coming down to distal, something here, and I would probably measure to somewhere around here. And then comparing that to the tachycardia cycle length. And another small little kind of useful tool to use is just to see where in the tachycardia you're pacing. Here you're pacing almost exactly mid-diastole, and you're accelerating. And it's kind of pretty short way to just say this looks like an isthmus ablation right in the middle. The more you go, the further you go, you're probably more towards the entrance. The closer your stem to QRS is, the closer you are more towards the exit. So, and I don't see now, Dinesh, did you measure this about the same?
About the same, a little further.
Yeah.
And I mean, the main for Chris and Seva, I mean, it's for practical purposes. I think what Christoph is telling is accurate. Like for boards, I mean, it gets a little nuanced, right? Like, I mean, if you truly look at this QRS, the paste versus um, the tachycardia, and there is some element of fusion there, right? How would you see?
Yeah, I mean, it's very subtle, but it's definitely there. So it also just depends on how much tissue you're capturing when you're pacing.
Right.
You can be capturing adjacent tissue if you're pacing at high output, and you're not capturing just that isthmus that it's moving through. Can you go back one slide, Dinesh?
Okay.
So this also, I know we're spending a lot of time on your slides, but there's so many nice components. Just looking at ablation distal, the signal on your catheter during tachycardia, you can see just how many components there are. Mid-diastolic, late diastolic, pre-systolic, whatever you want to call them. It's almost continuous electrical activity there. So it highlights two things. One is mapping systems are not very good at annotating these, meaning where does it take activation? And I do think it's important that the electrophysiologist or fellow step in and say, if we are going to map activation, where are we going to take these? And be careful not to be misled by your mapper. They're often very good, but you can be misled by activation here and miss something like this. The most important thing is to take your time if the patient's hemodynamically stable and annotate this by hand on your map. These are really, really, really important signals. They are spanning almost the length of the tachycardia and diastole, and this needs to be annotated with a, super colorful point on your map. Something that you're not going to forget, and that it may be that the tachycardia terminates bumping this area, but this is a very key spot for mapping. And sometimes it's not participating in this tachycardia, but it is a very slow zone of conduction that needs to be annotated.
I think, these are all points that we considered, and I'll just go through the case, rest of it. I think, the main thing, like looking at this carefully, especially for the board's purposes, and as well as in practice too. Uh, and like here, the question was like, am I in this outer loop versus am I in the critical isthmus? And for boards, I don't know how you feel. Like, this is probably not a question that you'll get, but like if you do get, like, I think this is what I would have marked it as outer loop, considering everything that we discussed. And so coming back, like the points that we were making, although like for boards, if I'm thinking outer loop, this is where we ablated and the tachycardia terminated immediately. Again, all the things that Christoph was pointing towards, like how our stim to QRS relationship was, the length of the electrogram during tachycardia, like signifying that this is probably the critical isthmus, and then the relationships of the post-spacing interval to tachycardia cycle length all pointed towards that. And to Chris's point, what he was mentioning is that if your pacing output is just above the threshold where you need to pace, you're going to probably be within the protected. Your virtual electrode is not going to be big, and you're going to capture the tissue within the isthmus. But in our case, like what we noted is like this was very high output. This was the max that that we could get, and like that probably resulted in this stim to QRS and all the relationship to be a little bit different, or like us having this manifest fusion than concealed fusion. And so it's very important to keep your output to just above the threshold. And again, like what Chris was pointing towards is trying to annotate these signals. Some of it becomes after the fact that you've done, and you go back and look at that this is where most of the tachycardia cycle length was along the septum, the mid part of the septum. And various things that you can do with it. Here we looked at it with activation map, and this is where the slow component comes, and this is with the other site near the apical septum where we were pacing from, where you have this like late activation that really doesn't have any participation into the tachycardia. And this is what we were discussing about the adjacent bystander. And there are many ways a mapper can show it to you. This is the psychedelic version of it. And again, looking at the map and voltage, this is where we ablated with one burn that we terminated the tachycardia. And after that, we went on and homogenized the scar. And that was the end of the case.
So I think Danesh is a fantastic case. I'd like to summarize with 3 points. So one is, take your time when you're trying to annotate these signals, understand which signal is local, which signal is far field. The one that is sucked in is your local signal, the component that is sucked in. The second thing is, understanding concealed versus manifest. So that would be the first step. You got to pay attention to multiple ECG electrodes. And then the third point that you made is to keep your output as low as possible. Sometimes do your entrainment in a unipolar configuration, tip to an indifferent electrode, so you don't have contribution of the ring electrode. Okay. Yeah. Thank you. It's a fantastic case, and we'll move on to the next case.
And then even after termination, you can see just 1 or 2 more ablation lesions.
Yeah.
So it's a pleasure to introduce Dr. Van Niekerk. Christoph is a colleague of mine in Florida and a specialist in ventricular arrhythmia mapping and ablation, and just a really great teacher. So Christoph, thanks for putting together the slides and spending the time, and appreciate it. Looking forward to it.
Okay.
Yeah.
All right.
Good.
My slides are a little bit different, and it's essentially a little bit more focused on anatomy and understanding what is your bystanders, and specifically starting here with outflow tract TVCs. And I want to kind of highlight this paper, which is just excellent at describing the anatomy and giving you a sense at what we're looking at when we're specifically looking at outflow tract TVCs and VT. And this comes even to ventricular tachycardias, to non-ischemic ventricular tachycardias, because there's very frequently periaortic VTs or perimitral. So just to, as a very quick highlight here, so right in the center of the heart is the LVOT with the aortic valve, the right coronary cusp, left coronary cusp, and the non-coronary cusp. So no arrhythmias, no ventricular arrhythmias originate from the non-coronary cusp, just because it sits much more closer to the atria. It's a fibrous tissue in this region. There's nothing for it to depolarize to. So we're really focusing on this structure here, which, as we go deeper, here is exactly what we're looking at. This is the ventricular septum, and this is the structure that sits between the LVOT and the RVOT. The RV sits as a crescent around a fairly circular LV. And these are some anatomical dissections, and what I would encourage all of you is that at any anatomical dissection that you can go to it. My further encouragement is don't listen to anything anyone says. Just try to find the structures that you're really interested in and dissect it in such a way that makes sense to you. And so here you can see on this specimen, and this was a sheep heart, I believe. But you can see very similar. Here is our mitral inflow, tricuspid inflow, and here's the aortic valve and the pulmonic valve. And this is the structure we're really kind of talking about, and which is when you isolate the whole septum. So here I've taken off the RV free wall, which would sit on this side. On the other side is where the LV would sit, and this is the septum. You can see how the aortic valve and the LVOT sits right on top of the septum. And in fact, if you look closely here, this is the right coronary cusp. The right coronary cusp sits right on top of the septum. So just thinking about when you're placing a catheter in that right coronary cusp, you're going to have forces of 20, 30 grams and really not cause a whole lot of damage because you're sitting right on top of the septum. So this is just as a little bit of an intro, and then going further on this paper, some circulation, this highlights very nicely the different morphologies as you're walking across the different areas of the basal RV and LV in the outflow tracts, all the way to the anterior mitral annulus and the anterior lateral mitral annulus. Just to highlight a few small structures before I go into a couple cases. When you're trying to identify these outflow tract type TVCs and VT, I start with identifying, is it coming from the I tend to start all the way at the left side because it's easier. So look at V1, and if it's a right bundle branch block pattern, you're coming from somewhere in the LV and a specifier off the septum. What I mean by that is that the septum is not included if you're having a right bundle branch pattern. The moment you have a right bundle branch pattern, you know you can go in through the LVOT or transseptal via the mitral valve and go and target a site somewhere more lateral and anterior on the mitral annulus. So this is all the way over at, let me just go to this here. All the way over here, here's the mitral annulus, looking at V1, very positive. Positive across the precordium is a very posterior structure, so all of these will be positive. And we're specifically talking about inferiorly directed TVCs. So you can see these are inferiorly directed on lead 2 and 3, negative in AVR, AVL. And then very lateral. The laterality will really play a role and also guiding you how far. So you can look at it's negative in lead 1. then you can go into the summit, and we'll have a case there in a little bit. But the point I really want to make is as you're moving across this from left to right, your V1 becomes smaller and smaller and more negative. Here you can see the left corner cusp, more and more negative. Now more negative at the right-left junction. Negative in V1, V2 has a little RS, and then sudden transition by V3. And then we kind of get to the RVOT, and RVOT just has a way later transition, usually after V4. So LVOT before V3, RVOT after V3. V3, a little bit of an equalizer, tends to be right on the septum, but there's a couple things that we can do to sort out whether to go to the LVOT or RVOT first. I just want to take a pause because I talked a lot. Chris, Dinesh, Siva. This is a high-level overview, but I'll go into the next part.
Yeah, I do. I use V1 as such a useful, I guess, linchpin for where you are. And I think of it exactly the opposite from Christoph. If you're right underneath V1, you're on the right. And if you're moving away from V1, because you're on the right, like RVOT, it's all negative. And then you start building your R wave that you start getting more and more posterior. And so it's exactly the same concept, but the more vector that's moving towards V1, the more posterior you are in the heart. And think of the left ventricle as the posterior ventricle, and your right ventricle is the anterior ventricle.
Okay, all right. So this is an example of a pure RVOT free wall PVC. And so thinking about this, right, the RVOT sits very anterior on the chest. If we're thinking about V1, V2 as unipolar electrodes, it's going to be very negative in the V1 and V2. So here is what the PVC looked like. So very negative V1, a slight R wave in V2. It's still negative in V3 as we're kind of here's V1, V2, V3. All of these signals are going away. And then it's not until we're getting to V4, V5, V6 that we're starting to build a little bit of positivity. And in this case, we put the catheter on the RVOT free wall. You can see that we're somewhat early, but a very nice unipolar electrogram. Do you guys want to, anyone want to comment on these electrograms here?
Yeah, no. So in the teal color, you have the bipolar distal electrogram, tip to ring, and then you have a unipolar one, either to the Wilson central terminus or an indifferent electrode in the IVC. The key thing to note is you can have a QS signal, but it has to have a sharp DVDT. Sometimes you can be floating in the cavity and you can get a QS. So we want to have a sharp negative DVDT on the unipolar electrogram that coincides with a crisp bipolar electrogram to be more confident of a better site for ablation.
Yeah, absolutely. And when you look, it can be kind of tough to determine where you want to measure to. So I'm very strict. I would really say that this QRS starts around there, and that this signal is not incredibly early. If you take the sharpest point here, if you take the very initial deflection up here, then you would say that this is maybe a far field component, and that is early. The other point that I want to make here is with this unipolar signal, why is a QS important? It's the same as the unipolar ECG electrodes V1 through V6. It can tell you information of directionality, which a bipolar electrogram does not necessarily give you. So in this case, it's giving you directionality, and that all of the electrical wavefront is moving away from that distal electrode. So you're at a place where there's quite a likely that this is the origin of this PVC in this case. So this is our electron-anatomical map, and we put the ablator right here. Dinesh, do you want to comment here on dangers, things to consider in this region?
I think two things.
Is he here?
I think two things too very important to consider in this area would be like you're in the RV working there is always right with the risk of pericardial effusion. The second thing is where you're in relationship to the coronary artery, the left main, and the proximal LAD, where you are would be the other consideration.
Yeah, very thin region right there, high perforation risk, and it's a very tricky area to maneuver the catheter. So this is a high perforation risk, and this is where one of the complications with big pericardial effusions can occur. Really monitoring on ice for echogenicity and for rapid echogenicity, and monitoring your impedance to make sure you don't have a steam pop in this area. And maybe not necessarily super testable on boards, but again, like fluoroscopy is an important part of electrophysiology. This is what the RAO looks like. And you can see we have a deflectable sheath pointing towards the RV, probably right at the tricuspid annulus. And here we are in LAO pointing straight towards us, and then this S bend to help guide us into that position. And okay, so this is another PVC, and PVC is in Gemini. Any, if you got the moderators want to comment on this PVC morphology and things that stand out.
Yeah. I think I was telling you this week, Christoph, I'm no longer in the business of ablating these. They make my life too hard. I've given up. This is a really tough region, and I also say I think I've been fooled a few times to thinking that it's not in the summit, and it is. And but I do. So first, a few things to think about. So outflow tract, of course, you've got positive 2-3 in AVF, and you're moving away from both shoulder leads. A little bit more to the left, so AVL is a little bit more negative. But this slurred, almost pseudo-delta wave in a couple of ones. You can see that in AVR, and you can see V1 is just really quite blunted. Initially, it's almost equiphasic or slow to get into the myocardium and take off. And so tough place to ablate. And from an ECG perspective, what are the other things that you wanted to pull out here, Christoph?
A nice term to memorize or to think of is a pattern break. So this, you can see here in V1, we start negative. We then get more negative. This is not like pure perfect pattern break, but it's in the realm of pattern break. It gets more negative, and then all of a sudden we have a transition or rapid transition in V3. This gives you a sense that this is somewhere in the summit region. And absolutely, like Chris said, like sometimes you get these and ablate them from the left coronary cusp, and one ablation, you're done. Other times you can be in the exact same ECG, and you can go into the GCV AIV, go in the left coronary cusp, go underneath it, and just no success. So that's kind of the main point on this ECG. On the anatomy here, I just want to point out a few of the structures and to think about. I do think this is important for boards as well, as when you're thinking about anatomy, is what is your neighboring structures. So the summit is here. You can see there is a probe. It's a little tough to see here, but there's a probe that's in the GCV that turns into the AIV as it turns down more anteriorly. We're kind of looking down as though we're looking down from a surgeon's view. This probe right here is in the left main going down the LAD. So here's our right coronary cusp sitting on the septum, left coronary cusp. Here's the right-left junction. And the mitral annulus would sit right here. So this PVC is coming right around from this region. So you could either use the vantage point of getting in the left coronary cusp and pushing anteriorly and ablating there. This is what this picture is trying to show here. These are all the different areas that gets you close to this region. And this was the same PVC that we mapped in the AIV. This is the earliest point. I think I have it right here. A little different view here. This is RVOT. This is the LV endocardium. It's right beneath the right-left junction, right around here. Here's our earliest spot in the AIV. So this is the GCV turns into the AIV. And trying to touch this little piece of myocardium is just incredibly difficult. So here is a small piece of signal. I don't think I have, unfortunately, a better picture here. And this is some of the ICE imaging from the RVOT. Just trying to think about all of the different neighboring structures for this. That was from the RVOT, and this is from the LVOT. So this one is from the LVOT. And then an importance of, if you're going to be ablating in the AIV, to get coronary angiography because of the proximity of the LAD and the left main in this region. So here is an RAO view, which is now not playing. There it is. And here's the LAO view. So we're trying to stay more than 5 millimeters away from that coronary artery. And then ablating. Oh, what is this? Oh. Ablating these two PVCs. And this is a separate case. I apologize. So this is a separate case here. So I just want to pause. Any comments on that previous kind of summit PVC?
Yeah. This is, go back a little bit, Christoph. Thanks. So really difficult area to ablate. Also, if you're thinking of going epicardial, you're between two major coronary arteries, and there's a lot of fat here. So also very difficult to ablate epicardially if you wanted to do an epicardial puncture, the proximity to the coronary arteries. But also, though, we end up ablating sometimes, as Christoph has shown here, from a few different angles and triangulating this and seeing where we get better penetration. And that does throw off your QRS morphology because you're affecting the exit. And I often see this happen, that you're using a fiduciary point and a part of the QRS for your fiduciary mapping point as your how early are you with your signal. Just remember that when you start ablating in this area, you really can change your morphology of your QRS, and you really, if you're going to carry on mapping in the LVOT or RVOT after you've ablated and your QRS has changed, you may have to tell your mapper to just reset where you're drawing your we're mapping from your earliest point on your QRS or your fiduciary point on your QRS. It can change, and you end up going through a few different morphology changes. And I think sometimes we actually end up isolating the area as opposed to focal ablation. You've got it from a few different areas. So low power in the coronary sinus and making sure you're away from the coronaries, and obviously alcohol could be considered here if you find a small venule that's adjacent to your earlier spot, and lots of nice mapping cases with the small two French catheters.
Going down the same pathway. So this is now a case where we're moving, and here you can see multiple PVCs, starting again with V1 being very dominant, positive across the precordium. This pattern here with inferior directed, negative in lead 1, puts you at the anterior mitral annulus or the alveostium. So there is 2 PVCs here. Either of you guys want to comment on these 2 PVCs and what they may have in common? I don't know if this is maybe too much of a trivial or a trick question, but go ahead.
There, when I look at V1 to V6, it's a positive concordance, basal left ventricle. And the only difference between PVC 1 and 2 that's kind of striking to me is lead 1. So basal more leftward is PVC 1. Lead 1 is negative, and a little bit more towards the aortic root is kind of PVC 2, where you have like a RS in lead V1.
It's a little more narrow, PVC 2, a little bit more slurred upstroke, so maybe epicardial versus something more endocardial, but similar kind of pattern.
Yeah, and I think this brings a good point, is trying to determine whether it's epicardial versus endocardial. So lead. I'm a very simple guy. I try to memorize just as few little things as possible, but when I think about epicardial, the things that really have high positive predictive values or sensitivities for making sure that this is epicardial or not is to look at lead 1. Lead 1 is a QS and PVC1. And that QS tells you that it's sitting all the way far lateral. There's essentially no positive forces going towards lead 1. And then the second thing, as Chris mentioned, quite a wide PVC in comparison. And yes, see exactly. So this is in the same ballpark, same zip code, same area. So
I didn't realize that we'd already gone past. So let's do 5 more minutes, Christoph.
Okay, we'll finish this case,
and then we'll call it a day.
Okay. Signals here. So here you can see that we have an EP star. Here's our fluoroscopy. We have a deflectable sheath and the CS. There's the EP star going up to the summit. Here's the LAO and the GCB. And here's our EP star signals. This is just to show the point of activation mapping. When you do activation mapping, find the start of the QRS. It's right at the initial upslope. And then find your earliest point. So here we can see we're well early on our EP star. Here is PVC1 with the ablator, with the earliest, just barely on time on the endocardium. But if you zoom in, you can see a little far field electrogram on ablation distal. So I just want to orient that my ablation distal, given that it's the most important one that I care about, sits on top. So here is the far field electrogram that shows that that's early. Then this is the position. It's in the endocardium. And this is PVC2. You can see PVC2 very early on the endocardium. And this is our activation map with the EP star and the AIV and the ablation catheter on the endocardium. And so realistically, what these two PVCs had in common was a blading where PVC was exiting, took care of both PVC2 and PVC1. Here you can see we're coming on ablation right here, and the PVCs terminate, never to be seen again.
Just illustrating how Christoph can kill two foci with one ablation lesion. That's how good he is. Yeah, there really is. It's a really cool slide, and we see that often with the fascicular system. There are a couple of different exits. So we're going to wrap up here. I just want to summarize the one or two things here. Just knowing the anatomy is so crucial, especially here when you look down on the top of the heart like that. This is the crux of the heart. This is where so many of the key structures, important structures, high-risk structures exist. And just knowing it really well, there's so many lovely anatomical dissections and looking at it, and obviously doing your own anatomy dissections to really understand this here. The electrograms, really leveraging the unipolar, making sure you have the DVDT coincidental with the start of your bipolar and making sure it's sharply negative. So this was fun. I enjoyed that. I didn't realize we'd gone past the time. And then I hope some of you can join us for the EP board review course, which will be virtual on the 22nd, 23rd of August. Christoph, Dinesh, thanks so much for preparing these. Siva, thanks for helping moderate.
Thank you, Chris. We're looking forward to seeing everyone at the board review.
Thank you.
Thank you, guys. Thank you.
Thanks, everyone.